Today we're going to explore non-invasive positive pressure ventilation as part of my learning plan. So first off, what exactly is it? Non-invasive ventilation is the provision of ventilator support through the upper airway by means of a mask or a similar device. A benefit is that no endotracheal airway is necessary. You may be wondering, why would you ever need to use non-invasive positive pressure ventilation? Well, oftentimes, we use non-invasive positive pressure ventilation due to a failure of the lungs in key gas exchange functions. We may see the lungs failing in reducing and eliminating carbon dioxide, where a client may become hypercapnic, or we may see a failure in oxygenation, where we might become hypoxemic. Respiratory failure can be broken into two categories. The first category is type 1 respiratory failure. We may see, in this situation, hypoxemic respiratory failure without hypercapnia. An arterial blood gas would show us a partial pressure of oxygen less than 60 millimeters of mercury. This is usually related to fluid in the lungs, collapse of alveoli, or ventilation perfusion mismatch. Oftentimes, we may see this in heart failure patients where they have pulmonary edema. As well, we might see it in cases of pneumonia. We may also see it in cases of pulmonary hemorrhage or acute respiratory distress syndrome. There's also type 2 respiratory failure, which we can refer to as hypercapnic respiratory failure. An arterial blood gas for this type of failure may show a partial pressure of carbon dioxide greater than 50 millimeters of mercury and a partial pressure of oxygen less than 60. We'll often see this in our COPD as well as our asthma clients, in cases of drug overdose, and lastly, in cases where we see post-extubation or chest wall abnormalities. So what can we do to improve ventilation and oxygenation for our type 1 and type 2 respiratory failure patients? This is where non-invasive ventilation comes into place. First, we'll start by talking about BiPAP, which is probably what you're most familiar with. BiPAP, or bilevel positive airway pressure. The key here is that it's bilevel, meaning 2 levels of pressure. A client wears a mask or other device and they're hooked up to tubing leading back to the ventilator. Air is blown through the mask, through the oropharynx, down the airways, and into the lungs, and it does this in 2 pressures. The 2 pressures are what we like to call IPAP, inspiratory positive airway pressure, or EPAP, expiratory positive airway pressure. We can refer to our EPAP as our baseline pressure of air. The pressure will not drop below this rate. We can set our EPAP on the machine to a pressure in centimeters of water. Our IPAP is the pressure that we set that will be blown into the patient's lungs when they inhale. So, it would look a little something like this. The EPAP, or baseline pressure, also called PEEP, is constantly blowing into the patient's lungs, and the EPAP is the amount of pressure needed to keep alveoli open. As the patient inhales, the IPAP pressure is initiated, and the pressure being blown into the patient's lungs is increased in order to increase tidal volume. Once the IPAP pressure is reached, the pressure falls and the patient exhales. Don't forget, they're exhaling against the EPAP pressure that remains constant. Now, you may want to ask yourself, are you treating the patient for a ventilation problem like COPD with CO2 retention, or for an oxygenation problem? If you take a look at the ABG, it may show that there is high carbon dioxide. In this case, you may want to increase the IPAP, because a bigger IPAP helps to get rid of CO2. Instead, if the oxygen is low, you can increase the EPAP. Whatever change you make the identical change to the other pressure. In acute settings, we'll often see BiPAP used for COPD exacerbation, pulmonary edema, CO2 retention, and when we want to avoid endotracheal intubation. In non-acute settings, We often see it used with chronic CO2 retention, such as COPD, when CPAP doesn't work for sleep apnea, and in neuromuscular disease. Next is CPAP, or continuous positive airway pressure. It only has one pressure, and this pressure is consistent. It's like a continuous EPAP. Its main goal, overall, is to improve oxygenation by keeping the airways open. It helps to recruit alveoli. It helps to make breathing a little easier, increase the functional residual capacity, and overall increases the oxygenation. In non-acute settings, we use a CPAP ventilator to treat obstructive sleep apnea. In acute settings, we can use CPAP for pulmonary edema or exacerbation of COPD with hypoxemia and no CO2 retention, or with chest wall trauma and pneumonia. Lastly, I'm going to talk about PSV, or pressure support ventilation, which is another mode of ventilation. It's one of the most common methods of ventilation. The patient triggers the ventilator both on and off, meaning patients can control expiratory times. It's a set pressure, but it is influenced by patient effort. Lastly, we're going to take a look at clinical assessment. It's important to take a look at the clinical status of a client, specifically their consciousness, chest wall motion, accessory muscles, respiratory effort, response to treatment, as well as all their vital signs. You also want to take a look at their ABGs. Measure ABGs after 1 to 2 hours after initiating non-invasive ventilation and reanalyze after 4 to 6 hours. Don't forget about the oxygen saturation either. Monitor continuously for over 24 hours after initiating ventilation. Thanks for watching.